Welcome back. Chapter 9, Technology and Health, takes a topic that has actually moved from the periphery of healthcare and health communication to its center in a remarkably short time. Think about telehealth, wearable devices, and mobile health technology. Accordingly, the central argument you'll see in this chapter will kind of come through explicitly by the end. Technology access is now what the FCC's Connect to Health Task Force calls a superdeterminant of health, meaning that broadband and device access don't just support healthcare delivery, they actually shape who gets healthy outcomes and who doesn't, somewhat on par with the social determinants of health we've been talking about through this course. For my health sciences and nursing students, this chapter will connect directly to the telehealth and remote monitoring tools you're already encountering in clinical practice. For my communication students, pay close attention to how digital divide research uses communication and media access data, such as broadband subscriptions, smartphone ownership, and other such access indicators in terms of understanding health equity in its own right. Health communication students will also see a lot of resonance with how everyday conversations are mediated by technology, from social media influencers to our conversations that are even generated through technological and digital platforms, and how we consume and make meaning of them in ways that actively shape our understandings of health, our health behaviors, attitudes, meaning making, and ultimately outcomes. One of the links I've embedded under this chapter slides is the one with the sunglasses. It's actually a YouTuber. Some of you might be very familiar with him, who talks a lot about technology and digital technology and its implications on everyday living. So take a look. It should be saying under the link that says slide number 1 under the lecture slides on my classes on Canvas. In technology and health, we're going to focus on 7 objectives. One of our goals is going to be to define and distinguish between telehealth, telemedicine, telecare, and mHealth. On the face of it, these sound like 4 very similar terms, but actually they are distinct and to the uninformed ear are frequently used interchangeably in casual conversation. But for those that are going through this course and ultimately as an outcome, we want to be sure we define these precisely today and understand what each refers to very clearly in terms of their distinctions. The second one is to identify the potential of wearable technologies in improving health outcomes. Many of us will actually maybe resonate with the Apple Watch or Garmin or devices that are more commonly used of that nature. Some of us may resonate with the blood pressure measuring devices, but actually these kind of span the gamut from the more casual everyday devices to really the more sophisticated ones and the more niche ones as well. The third objective is to describe how the digital divide is evidenced in wearable device usage. As technology has become more ubiquitous, more powerful, more of a superdeterminant of health, the digital divide and its implications on health have become that much more acute. Those who are on the other side of the digital divide or digital literacy from that coin, if you remember that chapter, are at greater risk of negative health outcomes, and by that same yardstick of a poorer quality of life and a diminished ability to achieve their goals or even to construct their goals and flourish in life. So we are going to describe disparities implicated in the medical device approval process itself as well and its implications. We're going to look at, to some extent, data privacy and security concerns influencing the adoption of mHealth and wearable devices. We're going to explain how the digital divide is experienced in low-income, rural, and socially vulnerable populations. And finally, we're going to understand the significance of technology in healthcare as a super determinant of health in accordance with all these objectives that we've talked about. So that's the ground we're going to cover in this lecture. And when we look at technology and health, following our earlier few chapters, going through environment, health literacy, healthcare relationships, and of course, understanding social justice and whole person approach to healthcare. Maybe it's appropriate to start with a brief self-reflection before getting into formal definitions. Try to think through each of these and note which ones apply to you. So these scenarios are examples of everyday contexts. Have you read someone else's experience with a health condition on a website, blog, or news group recently? Have you recently consulted rankings or reviews online of hospitals or other medical facilities or of doctors or other providers? Have you signed up to receive updates about a health or medical issue? Have you listened to a podcast about a health or a medical issue? Each of these everyday actions is actually, as you might notice, a technology-mediated health behavior. And if you have not really paid attention to that, it just illustrates how much we all take it for granted in present-day contexts. And that's my point here. Technology's role in health isn't an emerging futuristic topic. It's already deeply embedded in how virtually everyone in this course already engages with health information, and how the kind of information and digital literacy that we exemplify has, in material ways, whether we have reflected upon it or not, shaped our health outcomes. So a prompt, if you pause my lecture here, is to think about which of these 4 actions have you personally taken in the past year? Which one surprised you the most when you thought about how normalized it has become? Let's ground today's topic in some sobering national data on the relationship between income and technology access. Of course, this data keeps changing, but it's more or less changing in the direction of widening this gap. Among lower income households, which is those earning $30,000 a year or less, which makes up about 24% of adults in that population, say that they don't own a smartphone. And about 4 in 10 lower income adults do not have home broadband service, a desktop, or a laptop. Among higher income households, those earning about $100,000 or more a year, 63% by contrast report having home broadband service, a smartphone, a desktop, and a laptop. So you might be comparing this with just 23% of those in the lower income households that report the same full set of access. So you might see how these disparities are striking in themselves, and this gap is only widening. For now, you can see that nearly a 40 percentage point difference in full technology access exists between different income brackets. Every telehealth, mHealth, and wearable technology we discuss for the rest of today's lecture is filtered through this access gap before it ever reaches any one of us. Let's look at some definitions next. Our goal is to start by defining carefully 4 terms that are frequently used interchangeably: telehealth, telemedicine, telecare, and mHealth. Let's start with telehealth. HRSA, which is the Health Resources and Services Administration, defines telehealth as the use of electronic information and telecommunications technologies to support long-distance clinical health care, patient and professional health-related education, public health, and health administration. To that extent, you might say that telehealth has a really broad definition. It includes clinical care, but also includes education and administration. The utility of telehealth is wide-ranging. Patients can interact with their providers over the phone, send and receive messages using secure messaging, email, and secure file exchange, and use live video for home check-ins. Devices for monitoring vital signs can help a healthcare provider stay informed on a patient's progress remotely. I am sure many of us in class have either been, as in their internships or in their clinicals, familiar with the use of telehealth, or as patients interacted using telehealth with their providers. A key underlying value here is that individuals receive care in the context of their own environment, which could include their home, their daily routine, or the circumstances of their daily lives, rather than only within the walls of a clinical facility through a special visit to their provider. So even with this kind of a broad definition, you might sense telehealth's broad potential. However, real barriers limit who actually benefits from it. The availability of technological applications alone, as you might guess by now, through our literacy chapter and from the premise we've taken right from the initial start of this course, is that just because something is available, in this case technological applications, that does not mean that their access and use by those who would most benefit from them is automatically understood. What this implies is that availability and actual usability are not the same thing. Physical and infrastructural barriers, such as lack of devices, lack of broadband service, are real, and these are real barriers that limit who benefits from telehealth. Then we have psychosocial barriers, which might be just discomfort with technology. Often we think that's age-related, but if we move beyond stereotypes, it can be rural-urban divide, it can be education divide, it can be a cultural divide. So these sort of psychosocial barriers can span this identity and intersectional markers in terms of who is more discomforted with the use of technology, trust concerns, or a lack of confidence in navigating a video visit. The chart here, and it's also linked under the lecture on Canvas, on preventive medicine utilization by patient-provider race, concordance, similarity, is a useful reminder that provider-side factors, and not just patient-side technology access, also shape whether telehealth actually closes or widens existing care gaps. Next, we'll look at telemedicine. So telehealth, as you might have guessed, seemed like a really broad space. Telemedicine is a subset of telehealth and specifically refers to remote clinical services. Telemedicine focuses on the use of technology to deliver medical care from a healthcare provider to a patient who is situated in a different location. You might think about this as divided into two types: real-time or live telemedicine, which involves a two-way communication between a provider and a patient, oftentimes using internet-based technologies that facilitate real-time engagement like a live video visit. Or you could have what's called store and forward telemedicine. This involves the transmission of a patient's recorded health history and clinical data and is reviewed by a provider asynchronously rather than live. So that's where store and forward telemedicine gets its name, but both of them are clinically situated. Now you might think that telemedicine has, of course, great advantages, but it also carries with it real disadvantages, including a lack of medical insurance coverage, malpractice insurance coverage, and insufficient patient insurance for these visit types in many contexts. The barriers to adoption here, which can include implications down the line towards a digital divide, include age, level of education, lack of broadband and digital skills, cost, and poor e-health literacy among disadvantaged populations. You can think up more to add to this bag. But even so, notice the intersectionality that we have explicitly focused on in this chapter, which is that these factors don't operate independently. They compound and complicate adoption together, not as separate, individual, additive, added on kind of obstacles. I would like you to also, as I move on to the next one, which is telecare, dwell upon the intersectionality point I just mentioned and how age, level of education, lack of broadband, digital skills, cost, e-health literacy, and who is disadvantaged or minority, these all compound and are not separate factors. Next, we have telecare. Telecare is used specifically when the need for virtual healthcare services is emphasized. It's defined as care that involves technology allowing consumers to stay safe and independent in their own homes. So it's often described as care offered to patients remotely via telecommunications technology, either through synchronous means like live video or asynchronous means like store and forward data or remote patient monitoring. What telecare does is help expand patient access to care and help patients manage recovery and well-being at home. It helps providers monitor risk remotely, for example, catching early warning signs before they become emergencies, which is very significant in terms of its advantages. Equally importantly, telecare highlights how care is handled through a whole range of technology. It spans the gamut from your cell phone to virtual online visits to full remote patient monitoring centers. Of course, you might guess that the barriers here will be similar to what we've already seen with respect to those undergirding technology. Lack of equal access to technology and lack of insurance and access to treatment will impede who benefits from these, even when the technology and the capacity to avail of the benefits itself is available. Which is a real pause for thought here for everyone. Next, we look at mHealth. mHealth refers to the specific ways mobile technologies are utilized to achieve improved health goals. It focuses on user-directed health technology that falls into the fitness and well-being domain. Something every one of us in class can relate to. Think about smartphone apps that track your steps, sleep data, or heart rate. mHealth falls under the broader category of telehealth. Telehealth was, of course, the broadest of them all. At its very basic, many mobile devices now have GPS tracking and a feature that helps extend telecare accessibility to more people across different environments. Many mHealth systems help a person receive immediate feedback on their environment, health, or situation. Things that can help alleviate memory issues and help people maintain their dignity and independence, which is especially relevant for older adults or those managing cognitive decline. Barriers to mHealth adoption include the need for secure connectivity solutions that leverage genuine expertise in tamper-proof end-to-end security and affordability challenges. One of the big outcomes of this class is that we should all be very well aware of how the presence of the best case scenarios in each of these contexts does not guarantee the best health outcome unless we don't have the conversations around equity, inclusion, representation, accountability, collaboration, and innovation. And all of these are even more important than the cost and the budget itself of some of these, especially in today's chapter, technology-related discussions. Let's look at the wearable industry for a minute. You might find this link under the chapters My Classes Canvas slides, and it provides an infographic which lists 10 emerging technologies for 2024 relevant to the wearable and digital health space. And that will be under this one. Wearable electronics are defined as devices that can be worn or mated with human skin, and these continuously monitor an individual's activities without interrupting or limiting the user's motions. The potential of wearable technology spans chronic condition monitoring, therapy delivery, rehabilitation, diagnostics, and activity tracking. And these are all enabled by continuous data tracking and the ability to offer immediate healthcare interventions when something changes. With the broader digitization of healthcare, the increasing popularity of wearables and their growing contribution to healthcare decision-making has increased access and the potential of better health outcomes. We also see that the market expansion has been driven by several converging factors. In fact, the rise of lifestyle-associated diseases like hypertension, the growing demand for home healthcare, and the ongoing need to improve patient outcomes more broadly has also been a major factor in market expansion in the mHealth category and the wearable industry category. With the wearables, the factors that have facilitated their adoption include the provision of objective data that can inform patient-provider decision-making and enhance the quality of clinical encounters that move beyond a patient's self-report alone. That is valuable. Then we also have infrastructural factors such as the diffusion of the Internet of Things, that have shaped the adoption and integration of medical wearables into everyday life. We also have additional factors like the rising number of geriatric populations, our seniors, the prevalence of chronic diseases requiring a consistent monitoring system for better outcomes, and a growing focus on personalized patient care, alongside ongoing technological advancements in the devices themselves. All of these have come together to make wearable devices extremely popular and a promising market segment with increased adoption. So let's maybe take a quick look at their market growth and the projected market growth. And this tracks their trend in North America for wearable medical devices in terms of market size from 2019 to a projected 2030. At the time this chart was made, artificial intelligence was not around, so recent. So even though this is a steep curve, it's probably shifted quite drastically to be even steeper in terms of adoption. And you might see that it's going to completely be overwhelmed in terms of how technology and the wearable industry market growth is going to subsume almost every facet of our life if it has not already. So we're in about 2026, somewhat towards like the maybe fifth bar from the right hand side, and we may already have superseded this what this bar chart is showing us. With all this conversation, it might seem as though wearables and mHealth technologies are everywhere, and so we might reach some kind of Elysium utopia-like situation where good health and flourishing and optimum lifespans well lived are soon going to be a possibility for everyone. However, this is not evidenced by the fact that wearable devices are, as data shows, generally not used widely in low-income and minority populations. Market research here has shown that the representation of minorities and low-income groups in the research driving this technology's evolution has been lacking. So, with minorities and low-income groups being underrepresented in the research that guides these technologies, that means the needs of the people of color, rural communities, and populations with low digital literacy will be left behind in both access and utilization, and the ability of such technologies to speak to contextualize data that is relevant to these communities and populations. In this respect, two specific barriers to wearable device adoption stand out: cost and education. While broadband adoption and smartphone ownership have grown rapidly for all Americans in absolute terms, the digital lives of Americans with lower and higher incomes remain different in significant ways. Rapid overall growth has not closed this underlying gap. For my communication students and for those of us who are focusing on how we interact in clinical context using telehealth or mHealth or wearables, communication can play a major role in how we address this sort of gap. And so that is a food for thought we're going to come to later. In the meantime, let's connect wearable and mHealth technology back to whole person health communication. In this case, let's start with the lens of empowering patients. The link for both of these images and the data underlying both the infographic and the sleep data for a newborn is under the lecture. So let's connect them through mHealth to whole person health communication and empowering patients. First is the fact of data for insights. Patient data is collected and reported in digital format, and this can genuinely support patient self-understanding and provider decision-making. You might have some examples in this realm. Second, insurance companies rely on this data to design more personalized and accurate health plans. You can think of some upsides and perhaps even some downsides to this equation. Third, organizations are increasingly encouraging healthy habits for remote workers and employees, and they often use the same wearable and app-based data infrastructure. So definitely lots of avenues to think through here. However, keep in mind that there is a double-edged sword here. The same patient data that can empower a patient's own self-understanding is also being used by insurers and employers, which raises real questions about consent, privacy, and who ultimately benefits from the data. And this sort of thing extends now, as we'll see in the next slide, to disparities from research and the FDA approval process, so the structural realm. Let's go deeper into the technological and regulatory barriers facing wearable devices specifically. So we have a few factors here. The first is data privacy and security, power consumption optimization, wearability in design. So devices really need to be actually comfortable and practical for continuous use, and reducing the risk of data loss. There may be more recent ones here. There's a deeper structural challenge, whether these are newer challenges or some better documented ones that I've just mentioned, that faces the wearable industry. Implementing a high-risk medical device or drug therapy generally requires validation in a representative population. But for many wearables, validation studies were conducted in homogeneous samples that were never externally validated in more representative populations. And you might guess that the minority and disadvantaged populations don't usually volunteer, are underrepresented for a host of reasons. So you might think about the course materials, look into the links here under the slides on Canvas. Check out the My Skin Track UV resource under slide 17 linked in the course on Canvas for a really specific illustration of this validation gap in practice. And you'll see that for people of color, actually, that's an illustration. So this connects to a larger and increasingly urgent issue. Chronic disease management relies a whole lot more on the coordination of information between telemedicine, sensor technology, and artificial intelligence. With a lack of diversity in the study populations underlying these systems, such disease management research translates directly into poorly generalizable AI models, because the AI models are now trained on narrow populations, and thus they may not perform reliably or safely for everyone else other than the norm or the majority or the dominant population. Link for slide 18 should be under the lecture slides on Canvas, and do check it. So you may pause the lecture, take a moment to click that link and go through it. It shows a chart with the number of internet users worldwide in billions going from 2005 to 2019. And it illustrates, even though it stops at 2019, that even as global internet access has grown enormously in absolute terms, this growth has been distributed starkly unevenly. And that is what, at its heart, is what digital divide refers to. Let's step into the world of digital divide next. The digital divide's disparities stem from a range of systemic exclusionary practices, which sort of underlie the digital divide. And if we look at it from this social justice lens, we might say, looking back at those principles, that implicit bias is visible even in the lag in telehealth utilization and the conveniences that it offers. The HINTS database, which is the Health Information National Trends Survey, is a large, nationally representative, federally supported survey. So extremely credible for North America and American population. In that survey, the data shows that 60% of white patients say their providers have offered them online access to their electronic medical records, compared with about, let's say, 57% Black patients, 46% Hispanic patients, and 53% Asian patients. This is not a gap in patient interest or ability. It's a gap in what was actually offered to patients in the first place. Disadvantaged and minority populations, you can think about seniors, people with economic or social disadvantages, individuals who are disabled, those who are living in rural areas. These populations show consistently low telehealth use, alongside higher rates of chronic disease and premature death. So there is an association with the social determinants of health attributes like poverty, access to healthy food, safe spaces for physical activity, transportation, and employment opportunities. These are often more important and impactful than actually the provision of healthcare and clinical interventions in determining health outcomes. Technology is a material resource and very much core to the structural factors determining our health, hence its status as a super SDOH. At the digital data perspective, at the neighborhood level, really brings this home. Digitally disconnected neighborhoods in national data are also the most racially segregated neighborhoods. In the most digitally disconnected neighborhoods, 84% of residents are Black, while in the least digitally disconnected neighborhoods, about 3% or fewer residents are Black. About 80% or more of the residents live in more privileged suburban neighborhoods, have broadband subscriptions and smartphones. This is the data behind a significant policy development. I had mentioned the Connect to Health Task Force of the FCC that has argued that broadband should be recognized as a super determinant of health. So what does the super refer to here? Of course, we know that the social determinants of health reflect the fact that health begins where we live, learn, work, and play. And these are non-medical factors, including education, income, and employment, that these together affect health and can serve as predictors of our health status. By recognizing broadband specifically as a super social determinant of health, we can help it receive greater attention in national broadband policy, in population health efforts, and in government-wide initiatives to address health inequities. So this chapter emphasizes that technology and access is not just a convenience that we kind of say we offer above healthcare services. It is actually powerful enough to shape the effectiveness of everything else that we do to maintain and promote our health. In this lecture today, we've covered the distinctions and definition between telehealth, telemedicine, telecare, and mHealth. We've looked at the wearable device industry and the disparities in research, adoption, and regulatory approval. And we've considered the digital divide as a documented driver of health inequity, going all the way up to and including broadband status as a super determinant of our health conversations and health outcomes. So as you move on to the reading review and the engagement and advocacy application activities, think about what is one key takeaway from today's discussion on technology and health for you, and how would you engage that takeaway in your own community. As you do so, remind yourself of how telehealth, telemedicine, telecare, and mHealth each relate to each other, and to telehealth as the broadest of all categories, but also how these are distinct from each other. Think about and be clear about how real-time or live telemedicine is different from store and forward telemedicine in terms of how we present it, and how we communicate it, and how we make meaning from the data that we gather from it as providers and as patients and as consumers. Be ready to explain why a lack of diversity in wearable device validation studies is actually a health equity concern, and how can we present it as such and not communicate it as a technology limitation. According to the HINTS data cited in this chapter, think about how did rates of being offered online EMR access differ across white, Black, Hispanic, and Asian patients. And this is a communication issue which leads to disparities without really there being a disparity within the patient population, in this case themselves. In that regard, explain what it means for the FCC's Connect to Health Task Force to describe the broadband as a super determinant of health. With that, I'll leave you to take the engagement and application activities with the advocacy dimension and complete the reading review, and look forward to reading all your thoughts.